So I have to start by telling you guys a really fast story, which is I came downstairs this morning at 5:30 a.m., asked my nanny to come early because I was taking a 7 a.m. flight. And as I'm walking down the stairs, she said to me, "You look awful, so tired, like go back upstairs and go to sleep." And then I walked by her, and what she saw was the back of my jacket. And she said, "Now that is beautiful. Wherever you go today, constantly go like this so people are looking at your jacket and not you." So I have to give a quick shout out to Regina Holiday, who's one of my personal heroes. And if any of you guys have time today to go meet her, if you haven't already, or follow her work, you have to. So I work with a company called Eliza Corporation, and we are, I think the best word is really obsessed with helping people be happier and healthier and more productive. And we do that through an automated communications platform that sends out automated phone calls or texts or points people to a social networking platform or connects them back to live individuals, all with a focus of health engagement management. And what we do is sit on top of that platform, which in turn sits on top of a database of over 700 million interactions. And we really mine that data to pull what I would call signal from noise and to try and tease out ruthlessly what is it that makes people tick and how can we meet them in their reality, in their world, and guide them to a place where they are inspired and enabled and supported to make healthier decisions for their health. Last year, we had the great honor of being here and talking at Datapalooza about what we call the Engagement Index, which was the next generation of Eliza's platform called ElizaLive, which was, again, looking back on this database of over 700 million interactions to try and figure out what makes people tick, specifically in through a metric that we could measure and that we could create an index that lets us track people and specifically identify who might be not engaged, for example, since we found that to be predictive of whether or not somebody would take the actions that we wanted them to. And as importantly, if you have a population and you can map out that they are engaged or not as engaged, and you overlay that against health, for example, you can imagine, based on what you're looking at, you end up with a wonderful ability to sort of target what we all know to be extremely limited resources to say, this is a population that, for example, is more engaged and healthier. And so what we could do for them is spend less resources, just keep supporting in the great place that they already are, maybe send them an email with a link to a website that has topics that would be of interest in them and keep them on the healthy path that they are already on. On the other hand, if you have a population that's not engaged and is in fact perhaps not well, there's two things there. One, that's a place to spend more resources. This is a population that needs your help. But as importantly, it's clearly evident that the things that you've been doing historically are not working. This is a population that's not engaged. They're raising their hand and saying, I'm not interacting with you. And so what's the definition of insanity? Doing the same thing over and over and expecting a different response. The engagement index gave us an ability to go back to our partners and say, we need to try something different with this population. Let's look at, for example, something we know that's relevant to them. Let's see if there are any national conversations happening about that topic. Let's lead into a conversation with that individual where we want to talk about diabetes, but let's start with something that maybe feels more relevant to them, and then on the back end bring in the diabetes. And when we did that approach, we were able to increase engagement by up to 40%. So we kept pulling on this string of what drives engagement, what makes people tick, how can we get people to feel more inspired, to be more connected to the resources that exist, because there are a lot of them. And what we kept coming up against when we would talk to a woman about, please get a mammogram, or somebody with diabetes, please take care of your diabetes, in the cases when people said that they wouldn't, they very rarely said that they wouldn't because they didn't believe in it or didn't want to. What they said is, I just can't. I'm going through a divorce, I'm caring for an aging parent, I'm really stressed out because I just lost my job. And we really came to see these things as diseases in and of themselves, these life factors as perhaps as important as the traditional things that we were looking to help fix on behalf of somebody. The literature said that these things are prevalent. We wanted to see if this was in fact true. We used our automated communications platform to reach out, launched a research and analysis initiative in collaboration with Wendy Lynch and the Altarim Institute. She's our formal stamp of approval, known for being extremely buttoned up. And what we were able to find is that, in fact, 95% of the population reports experiencing at least one of these unmentionables, and 40% reports experiencing between 4 and 6 of them. As importantly, the literature points out that these things are actually correlated to health, that if you are going through a divorce or if you have a bad job, if you are a caregiver, it is in fact impacting your health. And we were able to prove Again, and I think you guys can read that stat right there, people dealing with 4 or 5 unmentionable issues are over 5 times more likely to report bad health. I think that oftentimes in the healthcare space, we try to solve problems for people that they don't necessarily want to get solved. Yes? So the unmentionables are a list of about 10 factors, and if you go to elizacorp.org, you can see them all. I'll tell you right now quickly, the primary ones are financial stress, workplace stress, being a caregiver, emotional stress, and they tap into additional factors as well, but thank you, Matt, that's a great addition. One of the things that we were worried about, or that we see a lot, is we in the healthcare space try to solve problems that individuals might not be prioritizing. And so we wanted to be sure that if we were getting obsessive really about helping people with these unmentionable factors, we should first ground ourselves in, do they want that help? Is this something that people want help with? So we did a survey to this end and in fact found that 80% of people want help with financial stress or being a caregiver. 80% want help with financial stress, 95% want help with being a caregiver. We also saw no difference, if you're looking at that chart, you'll see no difference between whether somebody wanted that help from the doctor or a health plan or employer. And I've been in this space for 20 years and I've never seen any data where people react the same in terms of their wanting help across those 3 entities, which in our opinion relates to folks basically saying, I don't care who helps me, just help me. One of the other things that we saw in our work was the presence of what we would call coping factors, positive and negative. Positive coping factors being people who have a strong network of peers, who have a strong sense of spirituality, or who exercise regularly. Negative coping factors being things like, I'm having trouble sleeping, substance use, or depression. And what we were able to map out over time was really a population based on an algorithm that took into consideration the unmentionable factors that you have, the number of these life factors going on for you, balanced with this coping, this positive and the negative. And you can basically lay out with the vulnerability index and see a population and how vulnerable they are and how that translates very specifically into what you're looking at right here is people who are more vulnerable reported 2 days feeling good in a week. People who are less vulnerable reported 7 days feeling good. You can use on that metric on the y-axis health, productivity, and that hangs. We're also trying to figure out for our customers constantly, so what, so what? So what are you going to do with this? Well, you can imagine if you have a population that you know is more vulnerable, you want to go and meet them in that place. There's urgency there to provide resources based on what's causing that vulnerability. But on the other hand, if somebody is much better with low vulnerability, you would want to just keep supporting them in that space. It was also important to us to track whether or not this translated into specific problems we're all trying to tackle, like adherence, and in fact it does. So what you're looking at, if you compare the yellow bar to the yellow bar, did you forget to take your medication? That same relationship holds. Twice the vulnerable population forgot to take their medication. Slightly more intentional question, I'm not taking my medication, I didn't take it. Usually a more intentional willful action, but you still see that same doubling. So again, the vulnerable population, much less likely to be adherent. Why does this matter? Because if you've got adherence programs and you're trying to figure out with limited resources to whom do you deploy them, start with your vulnerable population because you know out of the gate they're much less likely to be adherent. If we're all trying to drive outcomes, we have to know what influences them. And we wanted to look at the vulnerability index from the context of its predictive power. Specifically, how does the vulnerability index compare to a composite of 15 diseases, which is a traditional metric that we in the healthcare space use to understand a population and its health. And what we're able to uncover is that, in fact, the vulnerability index is close to 4 times as predictive of variability in self-reported health and 33 times as predictive in variability for productivity. And those are extraordinary statistics, and we'd be happy to share more. One other thing that's happened to us over the years is an awareness that sometimes in our 13 years we uncover things that we think are genius, and in fact when we dig into it more, it turns out we just uncovered a marker for something else. And we wanted to make sure that that wasn't the case with the vulnerability index. So we went to test and said, is the vulnerability index just another way of identifying a known risk factor like BMI or a known risk factor like being lower income? And in fact, that's not the case. There was no relationship to BMI, and there was only 1% of the variability in the vulnerability index that was predicted by income, 99% that was not. So in fact, we are sitting on something that is new. And my last point, quickly, is I love the data that Todd and that Datapalooza is all about. So sometimes we take this information to our customers and we say, the ones that we're working with, let's go address this. And what they say back to us is, I don't have any resources for caregiving, for example. And we were able to tap into the data that the government makes available that points out resources that the government has invested in, like elder care sites. And so now with our partners, we can say, if you see somebody who's highly vulnerable and you know it's partially related to them being a caregiver, you don't have to spend any money on that at all. We will drive them to a resource fully paid for by somebody else. And since we know being a caregiver is correlated with twice the rate of depression, at the same time, we can do more for these individuals and do things like point them back to sites local to them specifically that offer resources that are perfect for people who are having a hard time. And none of these demographics are going away. We're only going to have more caregivers with the baby boomers, and we all wish the economy would settle down. And since it's not, I don't think financial stress is going anywhere. And thank you.
Thank you very much, Eliza.
Nice job.
Our